Sounds great. Well, hello everyone, and thank you, Adam, for this wonderful opportunity to speak today. And as Adam mentioned today, for the next 45 minutes or so, we're going to be talking about pediatric stroke. And given that it's a really very large topic, I'm going to focus specifically on the pediatric arterial ischemic stroke. So first of all, I don't have any disclosures. And in terms of the objectives of my talk, we're going to spend some time talking about the specifics of clinical presentation and etiologies of the pediatric arterial ischemic stroke and how they differ from those in adult population. Very briefly, we're gonna discuss the current state of acute reperfusion therapies and implications from imaging perspective. And the majority of my talk, of course, will be dedicated to discussing the role of imaging and how we can help to timely diagnose and guide treatment decisions in children with acute arterial ischemic stroke. So first of all, just a few facts about acute pediatric stroke and why it's so important. Um, Increasingly, pediatric stroke is being recognized as a really important cause of morbidity and mortality in children. And it's among the top 10 causes of childhood death. While pediatric stroke is not as common as in adults, really a very large percent of children who sustain acute stroke are going to develop significant long-term deficits. Up to 75% of children who sustain stroke are going to have long-term neurological deficits. And unfortunately, up to 10% of children die as a result of acute pediatric stroke. So it's a really significant problem. And the problem is not just the numbers or how frequently we experience it, but also that there are multiple challenges in diagnosis of acute pediatric stroke, which are really unique to this population. So one of the biggest challenges that we can name include delayed presentation to the emergency department just because there is overall lack of awareness that acute stroke can happen in children. And there is also relative rarity overall of this stroke as well, which leads to lack of knowledge among the providers who take care of children presenting to the emergency room, especially if they present not to the dedicated pediatric hospitals. There are obviously challenges to acquisition of urgent neuroimaging, especially if we're talking about resource-limited settings, as well as much wilder overall differential diagnosis and much more common stroke mimics in this group. The studies show that between 70 to almost 90% of children who present with stroke-like syndrome, symptoms eventually will get diagnosed with some stroke mimics. And obviously that really complicates diagnosis, timely diagnosis of the minority of cases where children presents with true acute ischemic stroke. And what implication does it have in terms of the timing? So again, studies show that median time from symptom onset in children to seeking medical care is really highly variable, and it can vary from like 2 hours to almost 24 hours. And in this group, only 20% of children get to the emergency department within 6 hours of symptom onset, which is obviously not optimal. And even further, if we look at the numbers in terms of the median time to radiological diagnosis, that median time can be even longer, on average between 15 to 24 hours, indicating that definitely there is some room for improvement for all of those who are involved in care for children with acute stroke. So, similar to adults, if we're looking at the classification of pediatric stroke, it can be categorized as hemorrhagic or ischemic. And ischemic stroke further can be divided into arterial ischemic stroke and sinovenous thrombosis. And the rest of my presentation gonna be focusing on the arterial ischemic stroke. Another way to categorize pediatric stroke is also based on the child's age at the presentation. And depending on that, pediatric stroke can be divided into two big groups. So one of them is going to be perinatal stroke, and perinatal stroke will include all the cases that present between 20 weeks of gestation and up to 28 postnatal days. And the second bucket is the childhood stroke, which occurs between 29 postnatal days and up to 18 years of age. And overall, when we take a look at the distribution of all stroke cases, there is really very high concentration in the group of younger children. So if we take a look specifically at that group with perinatal stroke, between 20 weeks of gestational age to 28 postnatal days, that period accounts for almost 30% of all pediatric strokes that we're going to see. Further, if we're looking at children, infants younger than 1 year, up to 30% of all arterial ischemic strokes happen in this group. And finally, if we get a little bit further out, the 50% of all strokes that we see in pediatric population occur in children who are younger than 5 years of age. So this early childhood and years, the really critical period for development of acute ischemic stroke in children. And with that, we're gonna very briefly talk about perinatal arterial ischemic stroke, and then the rest of the presentation, we're gonna talk more about the childhood. So perinatal arterial ischemic stroke overall has very unique causes and clinical presentation as well as management approaches when we compare it to the childhood stroke. First of all, again, in terms of the classification, it can be further divided into fetal stroke. So everything that happens between 20 gestational weeks up to labor time, and then neonatal stroke between birth, the first 28 days of life. And finally, the third group, which is known as a presumed perinatal stroke. So the stroke that identified later and presumed to happen within this perinatal period. And overall, if we're looking at the whole group of perinatal strokes, up to 80% of those strokes, they're going to be arterial ischemic strokes. Now, in terms of the clinical presentation, really, they very different as we compare to older children and especially adults. So in this group, the most common presenting symptom is going to be seizures. And seizures are seen in more than 90% of all cases of perinatal stroke, and especially concerning if the neonate develops unifocal motor seizure of a single extremity, just because, again, that's going to be more indicative of a stroke in the MCA territory, as well as seizures that develop a little bit later after delivery, presenting starting after 12 hours after birth. Compared to adults, focal deficits really very not common in this group. We see them in less than 20% of cases. However, other non-specific symptoms such as encephalopathy, which can present with irritability and lethargy, as well as poor feeding and apnea, are really relatively common as well. And finally, later in infancy, development of early hand preference should raise concern for presumed perinatal ischemic stroke, which contributes to up to 30% of all cases of congenital hemiplegia. So let's just briefly talk about what are the main risk factors for development of perinatal stroke. And in a large percent of cases, up to 20% of all cases, we really don't have or we cannot identify any risk factor. In those cases where we can identify some factors, the major risk factors may include presence of intrapartum fever, presence of preeclampsia, use of instrumentation in delivery, emergency C-section, as well as need for resuscitation at birth. And overall, it's thought that all these factors, they just exacerbate the pre-existing hypercoagulable physiologic state of pregnancy and that prothrombotic nature of fetal blood, altogether eventually leading to thrombus formation. So in terms of the imaging findings, more than half of all perinatal acute ischemic stroke occurs in the occurs in the middle cerebral MCA territories, and more so often there is involvement of the left MCA territory compared to the right. And this predilection to left MCA territory is thought to be related to the presence of existed right to left shunt, such as patent foramen ovale or ductus arteriosus. And this is, for example, an MRI of a 6 days old neonate who presented with seizures and some history of meconium aspiration syndrome. And we can see in this case that there is a really large left MCA territory, acute stroke, and diffusion-weighted images. 3D TOF MRA was also obtained at the same time for evaluate for any associated vascular abnormalities. And in this case, we really don't see any significant vascular occlusion or significant luminal narrowing. And overall, as a side note, in this age group, in the perinatal stroke, in terms of the acute reperfusion therapies, they really has no proven benefit at this age for many reasons. One, some of those include that the small vessel size is just really very small, limiting vascular access in this population group. So overall, the management, even in cases of the large vessel occlusion, still gonna be just supportive. Other patterns of acute stroke that we can see in this age group includes basal ganglia, involvement of the basal ganglia and thalami with perforator strokes. And this cases and this pattern is more commonly seen with difficult deliveries, with babies who have sepsis, prematurity, or when there's present central venous catheter. So this is an MRI of a 5 days old neonate who was admitted with clinical sepsis and was on antibiotic treatment for 5 days when he developed this seizure activity, and that was what prompted the MRI imaging. And here we can see that acute stroke in the right basal ganglia perforator territory on diffusion weighted images, as well as corresponding increased T2 signal in the right basal ganglia as well. Another pattern of the perinatal stroke that also can be seen is involvement of multiple vascular territories. And those cases are more commonly seen in a situation with meningitis, when there is embolic states or hypercoagulable states. So here I'm showing the example of MRI that was done on a 29 days old baby with a complicated cardiac history, who has a hypoplastic left heart syndrome and underwent cardiac surgery. And several days after surgery, developed mental status change and seizures, which again prompted further evaluation with MRI. And here we can appreciate multifocal areas of acute infarct, which is scattered, which centered in the right hemisphere, involving both anterior and posterior circulation. And with this, we're gonna now switch gears and transition into the discussion of the childhood arterial ischemic stroke, and the rest of the presentation gonna be dedicated to this topic. So again, just starting with the clinical presentation, and in older children compared to neonates, the presenting symptoms often can be similar to adults. For example, now in this age group, hemiparesis, acute hemiparesis is going to be one of the more common presenting symptoms, as well as speech disturbance. And in cases when there is involvement of the posterior circulation, other presenting symptoms also can include vision changes as well as ataxia. However, it's also important to keep in mind that even in older children, presentation of non-localizing symptoms are really very common as well. And up to 50% of children with stroke can present and often have headache. Seizures remain also very common presenting symptoms. Up to 1/4 of all children with acute stroke will develop seizures as well as other non-specific symptoms such as altered mental status. So let's just briefly at this point discuss what are the acute reperfusion therapies that are available for children who have large vessel occlusion. And overall, similar to adults, there is TPA and mechanical thrombectomy. However, the difference compared to the adult stroke is that really in children, those acute reperfusion therapies have not been prospectively studied. And overall, their utilization happens for the most part on a case-by-case basis. And of course, for this reason, there is a lot of clinical variability with practices varying depending on individual institutional policies, as well as availability of the neurointerventional expertise at the time when the child is presenting. And looking at some studies that have been done in children, one of them is the thrombolysis in pediatric stroke study, or the TEEP study. It was a phase 1 clinical trial, the goal of which was to determine the safety and pharmacokinetics of IV TPA in children between ages of 2 and 17 years. And this trial was closed early due to low enrollment. And despite that, it still was very helpful just because it allowed to establish systems for the evaluation and care of a child with hyperacute ischemic stroke. And currently, the window for thrombolysis in children typically is within 4.5 hours of documented onset of symptoms. And usually this treatment is reserved for children who are older than 24 months of age and don't have any contraindications to administration of TPA. In terms of the mechanical thrombectomy, so the true safety profile of mechanical thrombectomy in children is not really known. In 2015, the American Heart Association and American Stroke Association, they issued the guidelines that stated that thrombectomy may be a reasonable treatment for patients who are younger than 18 years of age with acute stroke, though they did state that the benefits and risks of this therapy are really not well established in this group. So later, the retrospective SAVE child study also showed that endovascular thrombectomy is feasible in pediatric stroke and has a low complication rates. Also, this study showed that long-term neurologic outcomes were good for the most part, and short-term improvement in the NIH score was comparable with the short-term improvement in adult trials as well. Finally, the recently published study of the endovascular thrombectomy also concluded that endovascular thrombectomy is likely a safe modality in children. And overall, all these studies, they allowed to expand that potential treatment window for children in pediatric stroke up to and sometimes even beyond 24 hours. And in terms of the effectiveness of the endovascular thrombectomy, overall it varies depending on the underlying cause of the stroke. And generally, really good outcomes are seen, or better outcomes are seen in group of children who have cardioembolic acute ischemic stroke. So with this now, let's transition to the discussion of the role of imaging in the acute ischemic stroke. And of course, the first task is to confirm the diagnosis of stroke as well as exclude stroke mimics, which are very common. And after we confirm that the stroke is indeed present, other imaging can also help to identify the etiology, establish the timing, and facilitate treatment decisions by providing information on vascular distributions, on presence of arterial clot, associated hemorrhage in the brain, presence of acute or chronic arteriopathy. And later in the course of the stroke, imaging also is very helpful in documenting the evolution as well as providing prognostic information in those cases. It's very helpful. It's similar to adult patients. Time is brain in pediatric patients as well. And having a streamlined pediatric stroke protocol can substantially improve the outcomes in the emergency setting. So this study was included the survey of pediatric stroke specialists in the United States and Canada, and it showed that almost all pediatric institutions, they have an established acute stroke pathway, which includes activation of a stroke alert page. And this is an example of a acute stroke protocol that we utilize at Children's Healthcare of Atlanta. As you can see here, it's a pretty complex document. We're not going to be reviewing it in full details. The only thing that I just wanted to bring attention to is the central part, which is the goal of this, having this acute stroke pathway, is to get the team of specialists and to determine the imaging plan for the individual patient presenting with acute symptoms. So in terms of the choosing the imaging modality, really the choice of imaging modality in stroke gonna depend on multiple factors, such as patient status, the probability of having large vessel occlusion, MRI availability, or anesthesia requirements. When we're looking at CT and CT, of course, its significant benefits include its widespread availability, it's fast, and it has a high sensitivity for acute intracranial hemorrhage. At the same time, CT really has low sensitivity in detecting acute stroke and mimics. It does expose to ionizing radiation, and it does require administration of contrast for vascular imaging. Compared to that, MRI has benefits of really high sensitivity and specificity for parenchymal and vascular evaluation. It does not require any contrast, or it does not expose to ionizing radiation. At the same time, MRI also has its own downsides, which includes often limited access, especially after hours, as well as often requirement for sedation and MRI safety considerations, which can be really a significant limiting factor in a cardiac patients, which are a large patient group who often develop acute stroke. So with this, MRI is considered the modality of choice in pediatric strokes, and most surveyed institutions prefer utilizing MRI and MRA over CT. At the same time, CT still can be utilized in certain circumstances. For example, if we're dealing with the medically unstable patients, when there are contraindications to MRI, such as MRI safety issues, when there is really no, in cases when there is no rapid access to MRI in acute settings, it's much better to get quick CT, CTA rather than wait another couple of hours to get access to MRI in those cases. And in some cases, it might be considered when there is a really high clinical concern that this may be hemorrhagic stroke or large vessel occlusion caused by clot. So when we're talking about non-contrast CT, diagnosis of acute stroke and non-contrast CT can really be very challenging, especially in the early hours since symptoms onset. And potentially, it could even lead to the delay in diagnosis if stroke is not being considered clinically. Overall, the primary role of the non-contrast CT is to evaluate for presence or absence of intracranial hemorrhage. And here I'm just showing an example of a CT, non-contrast CT head in a 12-year-old who has a complex cardiac history with dilated cardiomyopathy and was in hospital status after orthotopic heart transplant when this patient developed acute right hemiplegia and aphasia and was very rapidly brought to the CT scanner within 1.4 hours after since the symptoms onset. And here you can appreciate that really all the findings of acute stroke on the scan that we can appreciate is this very subtle hyperdensity of the left MCA, while the rest of the exam looked completely normal with no really any areas concerning full loss of gray white matter differentiation or any other signs of acute ischemia. And you can imagine that without appropriate history, it could be really very difficult finding and sometimes not very specific to even comment on it. So overall, talking about the early signs of ischemia, again, like I just showed in the prior case, presence of that hyperdense vessel sign, which again, sometimes can be very difficult to identify as sometimes even just hemoconcentration can look similar to that, but when it's present very focal and unilateral, it's definitely more concerning, especially when matches the symptoms that patient has. Other signs that we can also appreciate on a non-contrast CT will include hypodensity of deep nuclei in case, like in this case of the right MCA stroke, and insular ribbon sign with the loss of gray white matter differentiation, as seen in this case of an acute left MCA stroke. Um, Aspects is just the probably everybody's familiar with that. It's just the quantitative scoring system that was developed to increase reliability of detection of early signs of ischemia in the MCA territory. And it's quantitative 10-point system where 10 points is normal and then 1 point is subtracted for each region that demonstrates signs of early ischemia on non-contrast CT head. Simultaneous acquisition of head and neck CT images from the aortic arch to the vertex can really enhance diagnosis of acute stroke, but allowing direct visualization of that large vessel occlusion, but also providing information on the status of the collateral vessels, clot burden, and reduced regional blood flow. Obtaining high quality CTA and those emergent settings sometimes can be not the most easy task, but it's definitely very helpful. And again, this is that case that I showed earlier where the only imaging finding that we appreciated on non-contrast CT head was the hyperdensity of the left MCA, and then on the corresponding CTA, you can appreciate this clot within the left M1 segment, which corresponds to the hyperdensity on the non-contrast CT head. So with those findings, patient was taken for the mechanical thrombectomy, and this is the brain MRI that was obtained 12 hours later. One can see that overall the extent of the ischemic injury is limited to the basal ganglia, while the rest of the MCA territory is spared in this case. In acute stroke settings, when MRI is available, utilizing abbreviated MRI stroke protocol can really be very helpful. And this is the example of the abbreviated stroke protocol that we use at Children's Healthcare of Atlanta. And it includes DWI with ADC maps, susceptibility weighted images, T2 FLAIR. We include ASL perfusion as well as 3D time of flight MRA. And really, this protocol is helpful because it's tailored to diagnose acute stroke or its mimics, as well as provide critical information to guide treatment decision. And at the same time, it's really has a very short acquisition time. So overall, this protocol runs in about 10-15 minutes, which obviously helps a lot to avoid the need to sedate children as well as limit motion artifact, which can happen during the examination. Diffusion is really the sequence of choice to detect the ischemia and shows that reduced diffusivity within minutes of the infarction. And it should be definitely the first sequence run within this protocol, just because it can provide the most critical information in terms of the treatment, demonstrating the extent of the stroke and vascular territory. And this is an example of the small acute stroke in a 12-year-old who presented with acute mental status change and right facial droop. And another just small note that I wanted to make is that it's also important to keep in mind that pseudonormalization of ADC maps happens sooner in younger children. So in younger children, we can expect to see it in about 5 to 7 days, while in older children, it takes approximately 1 week for that pseudonormalization to start developing. With the utilization of the abbreviated MRI protocol, the modified pediatric aspect score was also developed, and compared to the CT aspect score, this scoring system actually includes 30 points. And in addition to the 10 regions that we count for in the CT aspect score, we also include 2 regions of the anterior cerebral artery, as well as 3 regions in the PCA territory. Susceptibility weighted images or gradient weighted images also very helpful in evaluation of the acute stroke, just because they allow, first of all, detection of the intracranial hemorrhage, but then also the sequence is really very helpful in detection of intraluminal thrombi, as well as evaluation for gross asymmetries in vascular perfusion and differential diagnosis with stroke mimics, one of which hemiplegic migraine is really very commonly seen in children. So this is an example. This is a case of a 15-year-old with a small acute right parietal stroke. And here on SWI images, we can see this really very small intravascular thrombus in the right posterior sylvian branch of the MCA. And when corresponding this area to the CTA, we can see corresponding abrupt truncation of this vessel on CTA. And you can see how difficult it could be just try to identify that abrupt truncation on CTA, and the SWI is really, really very helpful in this case to visualize this intraluminal thrombus. The role of flare sequence also helpful. It helps to, in correlation with diffusion weighted images, it helps to grossly estimate the timing of the insult. In particular, lack of signal abnormality on flare sequence, while in the presence of restricted diffusion is known as a DWI flare mismatch, and is seen approximately within the first 5 hours after the symptom onset. It takes about 6 to 12 hours for this flare hyperintensity to start fully develop, and eventually associated edema develops within the next 24 to 48 hours. And we can appreciate this MRI images of a 4-year-old with right-sided weakness in dysarthria and acute left basal ganglia stroke. The first MRI was obtained within the 4 hours after the symptom onset, and really we don't see any significant flare hyperintensity corresponding to the restricted diffusion, while it's fully present when we repeated MRI 24 hours later. Craniocervical MRA is similar to CT, is also part of the acute stroke protocol, and it's really helpful to evaluate the site and degree of luminal occlusion of the involved vessel, as well as to identify other abnormalities such as arteriopathies or dissection. It's important to include neck MRA in the protocol as well, just because up to 20% of cases will have abnormality in the neck, such as craniocervical dissection or embolism. And here I'm just showing an example of images of a 16-year-old with really no prior past medical history who was admitted with acute aortic dissection and throughout the course of his in-hospital stay started complaining about blurry vision, which prompted this brain MRI where we identified the acute stroke in the right occipitotemporal area, and then craniocervical time of flight MRI really showed this very extensive tortuosity of the vessels in the neck and head, which was really suggestive of an underlying diagnosis of Loeys syndrome, which eventually got genetic confirmation in this case. So just an example how MRI can be helpful in cases of acute stroke. And finally, while a few words about the perfusion images in the acute pediatric stroke. So overall, perfusion is much less studied in children compared to adults. And we all know that in adults, in the area of the ischemic tissue, there can be roughly defined three regions: irreversibly infarcted core, the area of tissue at risk or penumbra, and then the region of the benign oligema that not supposed to progress into the infarction. And utilizing combination of perfusion and diffusion-weighted images can help to define those regions and select patients for late window acute reperfusion therapies. And for this reason, perfusion in adult population is recommended as part of the acute stroke evaluation for those patients who present between 6 and 24 hours after symptom onset. So when we're looking at adult parameters, the core infarct is defined as the decrease of the relative CBF less than 30% on CT perfusion or decrease in ADC less than 620. And penumbra is usually defined as prolongation of Tmax greater than 6 seconds. It's important really to keep in mind that in children, all those parameters, they're really unestablished, and adult threshold in perfusion, they're used on a case-by-case basis. So this is an example of how perfusion can be utilized in pediatric stroke. So this is a case of a 15-year-old who presented with one of those non-specific symptoms with altered mental status, initially to the outside hospital, and eventually was transferred from the outside hospital to Children's Healthcare of Atlanta. And at the time of presentation, it was 15 hours since symptoms onset. And our neurointerventional team, they wanted to obtain perfusion to further evaluate the status of the core and penumbra. And we can see on this corresponding images on the right-hand side, those are DWI maps. And on the left-hand side, we have RCBF maps that was done DSC MR perfusion. And we can see that there is really large acute infarct in pretty much majority of the left MCA territory. And what's most important is that on DSC perfusion images, there's pretty much matching perfusion defect in the left MCA territory. And in this case, this study was helpful just because the decision was made that this is really not the case that should be taken for any endovascular treatment, and mechanical thrombectomy was not pursued in this case. Just a few words about ASL perfusion. Really, as a non-contrast perfusion technique, ASL perfusion is really widely utilized in overall pediatric imaging, and as I mentioned earlier, is a part of our standard stroke protocol. And it's really very helpful in terms of non-contrast identification of perfusion abnormalities and areas of hyperperfusion in acute stroke. It is important to keep in mind that ASL perfusion is prone to a number of artifacts, such as which can mimic large perfusion defects. And additionally, studies show that ASL may overestimate the extent of penumbra compared to DSC perfusion. And as such, it's important to keep it in mind and interpret ASL images with caution in those cases. So this is another stroke case just to illustrate the value of perfusion. So this is a 9-year-old who presented with right-sided weakness and seizure-like activity in the morning. And the last known well was the night before. So all that we knew at that time from presentation was less than 24 hours. On CT and CTA, we see the early signs of ischemia. We see the hyperdense left MCA sign. Here we also see hypodensity of the deep gray matter nuclei in the left MCA territory. And then CTA, I'm showing just one image, but CTA actually confirmed occlusion of the entire left internal carotid artery, starting from the bifurcation in the neck and further extending into the left MCA territory. And eventually it was thought that likely was a case of suspected cervical dissection as the underlying etiology. So in this case, again, just to guide treatment decision, we obtained rapid MRI protocol. And mainly the question was to assess the penumbra. In this case, we utilize the ASL perfusion. And here we can appreciate acute stroke in the left basal ganglia, which looks pretty matched between DWI and FLAIR images. And then on ASL RCBF map, we see a perfusion defect, which is significantly larger compared to the area of restricted diffusion on DWI, which is suggestive of a relatively large area of penumbra in this case. And in this case, this patient was taken for mechanical thrombectomy and had a relatively good outcome with the area of acute ischemic injury limited to that initial region of the left basal ganglia. And finally, another technique that also can be utilized and just mentioned is wall imaging, just because it can be helpful in some cases with vasculopathies, and especially can allow a pre-contrast identification of the intracranial arterial dissection, as well as abnormal wall enhancement in active inflammatory processes. So now let's just talk about risk factors and causes of the childhood stroke. And overall, they are quite different compared to adult population. The largest group, so the largest risk factors of stroke in children, they include intracranial and extracranial arteriopathies, as well as cardiac disorders. While other etiologies, which may include infection and inflammation, genetic and metabolic disorders, disorders of coagulation, they're seen in a much smaller number of cases. So in 2011, the International Pediatric Stroke Study proposed a cascade criteria, and with the goal to improve classification and reporting of the childhood stroke. And this classification, primary classification, is based on the location and nature of the abnormality. And then the chronic classification takes into consideration also the temporal features of the vasculopathy evolution approximately 3-6 months after initial presentation. So childhood arteriopathies are the most common identifiable cause of the pediatric stroke. And in the VIP study, which was vascular effects of infection in pediatric stroke study, arteriopathy was defined as an in situ abnormality, which could be stenosis or occlusion, which was not attributable to the thrombus and not considered a developmental variant. And the most common arteriopathies in that study were craniocervical dissection, focal cerebral arteriopathy, inflammatory type, and moyamoya disease. So let's now just quickly take a look at some of those cases. So first of all, focal cerebral arteriopathy is defined as a unifocal and unilateral stenosis and irregularity of the large intracranial arteries of the anterior circulation. And it can be further divided into two subtypes: FCA dissection type, which represents intracranial dissection of the anterior circulation, which typically is seen with trauma, and then FCA inflammation type, which presumed to be inflammatory in etiology and thought to represent a focal vasculitis. So, when we're looking at the FCA inflammatory type, it's suggested that possible etiology for this process could be infectious or peri-infectious process that leads to localized vessel inflammation and thrombus formation. In the VIP study, this FCA inflammation type was seen in younger patients. On average, they were between 8 and 15 years old. And patients in this group, they tend to have smaller infarct in the lenticular striate territory, as in this example that I'm showing on the right in the left basal ganglia. And more common in this group were isolated involvement of the M1 segment of the MCA. And presence of this arterial banding was considered pretty pathognomonic feature for FCA inflammation type. However, it's important to keep in mind that it's seen really in a small percentage of cases. Only up to a quarter of cases demonstrate that imaging findings. And also, of course, vessel wall enhancement, presence of it in vessel wall imaging is also helpful and in establishing this diagnosis. So looking in terms of the overall evolution of imaging findings in the course of the FCA, typically it has, in short term, it has a monophasic course, which with early progression, and then findings tend to plateau by approximately 6 months since the symptom onset, and subsequently develop either stabilization or improvement in imaging appearance. It's also important to keep in mind that long-term, this type of vasculopathy, it carries approximately 25% of a recurrent stroke, which is not insignificant. So now transition into the second type of the focal cerebral arteriopathy, or FCA dissection type. So in this group, in the VIP study, again, they found that usually these patients were presenting with history of head trauma, and they more commonly had arterial occlusions compared to the inflammation type. Up to 90% of cases presented with arterial occlusions. Typically, the infarct volumes in this subgroup were larger, and often they had coinciding abnormality of the cervical artery as well. On imaging, we can, in some cases, visualize not just arterial occlusion, but we can see intimal flap and mural hematoma. And usually when we're utilizing vessel wall imaging, less prominent vessel wall enhancement is appreciated. So this is an example of a FCA dissection type, and this image is just a bit motion degraded, but hopefully you still can appreciate this linear dissection flap within the proximal left MCA. So now transition into another common arteriopathy seen in childhood stroke, which is moyamoya. And as we all know, that can be primary, known as a moyamoya disease, and that commonly seen with mutation RNF213, or it can be secondary, such as post-radiation or associated with sickle cell disease or Down syndrome, and overall represents a progressive disease of the distal ICAs as anterior circulation, as well as can involve posterior circulation as well. Characteristically, we can see development of lenticular striate collaterals, and in moyamoya disease compared to others infarcts, often we see involvement of multiple vascular territories, and as I mentioned earlier, posterior circulation involvement in approximately 20% of cases. Approximately 20% of acute stroke in children is related to vascular dissection. And in this group of children, we more commonly see this in boys, as well as in those who present with history of head and neck trauma or connective tissue disorders. And then, in terms of the imaging findings, as shown in this example of a 17-year-old with the right vertebral artery dissection, on T1 PET-CT images, we can appreciate T1 hyperintense intramural hematoma, dissection flap, overall caliber irregularity or occlusion, as well as corresponding associated infarcts. Cardioembolic strokes overall represents approximately 1/3 of all childhood strokes, so also a very large group of patients. And usually the pathophysiology is thromboembolic, although some other associated abnormalities of the vessel of the head and neck also may be present. So in that VIPS study, when the investigators specifically looked at this group of patients, the characteristic imaging features were more common vascular occlusion, which was present in up to 50% of cases, while vascular stenosis and vascular caliber irregularities were really not a typical imaging finding in this group, though again, they can be seen in a minority of patients. And this is an example of an acute stroke in a 4-year-old who has a history of atrial septal defect. And here again, we can appreciate occlusion of the left MCA with a thrombus, which demonstrates that characteristic appearance in SWI with blooming, as well as areas of acute stroke, the largest in the left basal ganglia. But then again, we can see this smaller area of infarct in the right cerebral hemisphere, which corresponds to that typical multiple vascular territory involvement in cardioembolic stroke. And the last group of etiologies that I'm going to briefly mention is the overall vasculitis and secondary vasculitis, which can be of infection, well, not the most common group, and represent less frequent cause of acute ischemic stroke, but still can be seen. And this is an example of a vasculitis in a 3-month-old with pretty extensive group B strep meningitis, as well as other intracranial infectious processes, including the development of empyema and ventriculitis. And in this case, we can see this really large MCA territory infarct with, again, complete occlusion of the left MCA responsible for this imaging findings. And next, just a few words in terms of the subacute imaging. So after thrombolysis or thrombectomy, usually follow-up scan is obtained within the next 24 hours, just for routine surveillance. And the things that we're going to be looking for, it's going to be monitoring of infarct evolution and complications such as hemorrhagic transformation, infarct extension, mass effect, herniation, but also evaluation for stroke recurrence. It's really important to keep in mind that the recurrence rate of stroke in children is substantial. Approximately 7% of patients going to have recurrence at 1 month mark, while 12% going to have recurrence at 1 year mark. And in terms of the predictors of those who have a higher risk of recurrent stroke, presence arteriopathy carries a 5-fold increased risk for that, as well as a higher risk seen in children with posterior circulation strokes. And this is just an example of a value of subacute imaging in a child who underwent mechanical thrombectomy for left MCA clot, and post-mechanical thrombectomy, we can see this focal hyperdensity in the area of acute infarct in the left basal ganglia. And that's where the dual energy CT can be helpful, just because utilizing virtual non-contrast map allows us to differentiate a smaller area of parenchymal hemorrhage form the larger area of contrast staining post treatment. Finally, the last slide is on the long-term follow-up, which usually imaging follow-up is going to be obtained 3 to 6 months after the initial acute ischemic stroke. And what are we going to be looking for? It's screening for silent infarcts, evaluating the known arteriopathies, and assessing for interval evolution of the imaging findings, as well as identification of arteriopathies that were not obvious at the time of initial stroke, and evaluation of long-term complications, for example, pseudoaneurysm formation after the dissection. And with that, just to conclude, just a few take-home points is that to think about pediatric stroke and its mimics, and remember that clinical presentation often can be very non-specific and non-focal, because timely and accurate neuroimaging diagnosis is really critical as hyperacute reperfusion therapies become more and more available for children. Overall, MRI is the preferred imaging modality in pediatric stroke if available. And in terms of the major causes of acute pediatric strokes, those include craniocervical arteriopathies and cardiac disease. And with this, those are my references, and I would like to thank you all for your attention.
Thank you so much, Anna. That was wonderful. Very comprehensive, really great pictures. And yeah, this was really awesome. If anybody has any questions or comments, feel free to put them into the chat. If anybody has anything they'd like clarified. Chat's disabled. Okay. Oh, there we go. Try now. Chat should be working now. There we go. Laura is awesome.
Thank you. Thank you, Laura. And thank you, Adam, for this opportunity to present. I really love this Peanut series, and I think it's really amazing.
Well, thank you so much. Thanks for agreeing to speak. And Sarah says, excellent presentation. Thank you very much.
Thank
Yeah.
you.
So thank you so much. Thanks to everybody who joined. And thanks again, Anna, for this wonderful talk. And hopefully we'll see everybody next time.
Sounds great. Thank
Have a
you.
great
Thank you
day.
all. Have a great day. Bye.